Hello, I'm Ibrahim Imam, and welcome to another episode of the Neurology Lounge podcast. In this episode, we'll continue our discussion on depression. In the previous episode, we looked at the clinical and the academic aspects. Today, I'll be joined by Linda Gask, who is a retired psychiatrist and who has written a memoir of her own experience of depression in a book titled The Other Side of Silence, a psychiatrist memoir of depression. Linda Gask retired from clinical practice in psychiatry in 2013 after training in medicine in Edinburgh and after working in the UK NHS and at the University of Manchester, where she is now Emerita Professor of Primary Care Psychiatry. During COVID, she worked virtually and helped to set up and provide clinical supervision to Greater Manchester Bereavement Support Service. She has worked as an advisor to the World Health Organization and has been on the board of the World Psychiatric Association. Linda Gask was a 2017 recipient of the Royal College of Psychiatrists President's Medal, and she was the presidential lead for primary care and community assets from 2020 to 2023. That was just last year. Having co-founded the Storm Suicide Prevention Training Organization, she also helped to establish 6 Degrees Social Enterprise, which provides psychological therapy services in Salford. And she now serves as vice chair of the Blythe Trust, the mental health voluntary organization in Orkney, where she now lives. I'll probably ask you a bit about these organizations later on. And I'll also ask you about your latest book later on, which is Out of Her Mind, How We Are Failing Women's Mental Health and What Must Change. Linda Gask, welcome to the Neurology Lounge podcast, and I'm very happy that you've accepted my invitation. The first question usually is why did you write the book? What was your intention or goal in putting your experience down on paper?
I found that I wrote that book over the course of several years, and partly I think it was sort of self-therapy, because I do find writing is a way of making sense of what's going on in my head. I think most of us who write for that reason largely, and it helped me to make sense of where I was at in the world. But publishing it was really, a lot of that was to do with stigma. I was really aware that doctors just at that time, and I think they still don't, but I think more so now than they did 10 years ago, just didn't talk about mental illness, having mental illness themselves. And I had mental health problems throughout my life, particularly since I was a medical student. And there did seem to be a tremendous amount of stigma about even mentioning it. Can I even go on and be a doctor because I've had depression? And it was obvious to me that many of my colleagues had problems that sometimes they didn't seek help for. And I treated doctors when I was a psychiatrist and nurses. So really trying to say, look, we're not that different from our patients. And that was partly the theme behind the book, of comparing and contrasting, things that were going on in my patients' lives. And I spent a lot of my life working with people with fairly common mental health problems, had resonances in my life. We're not some kind of separate species from our patients.
I think our training probably has set us up to fail in that regard. We are
absolutely, yes. Yeah.
And did you start writing after you retired, or did you start whilst you were still in active practice?
I started about 10 years before I retired. I did actually start writing. I started writing during a period when I was recovering from depression. I started writing seriously in the 1990s, when I was in my 40s. And then I'd always wanted to write, but never got round to it. And I wasn't well. I was off with depression, and partly what I wanted to do was to just get away from medicine. And I was starting to having to write academic papers, and it was really refreshing to be released from the framework of writing academic papers. And then I took up writing more seriously over the 10 years before I retired, and I wrote bits of this book. I'd go away on holiday for a couple of weeks on my own and try and write a chapter. I joined in on online writing courses where I would submit chapters, and then at the end of, and I also went on I got to do a residency in a wonderful place in Oregon for a couple of weeks. Just applied for it. I'd apply to go and do stuff where I could do writing by submitting some writing. And at the end of that, I had something that was just about ready to submit, but I had to get more input on it and advice. But eventually it got accepted and published in 2015.
Okay.
So it was a long time in the making, that book, a very long time.
Well, you clearly put a lot of effort to make sure it was perfect, I guess. Is that a reflection of some obsessiveness on your side?
I am a perfectionist, and also, I mean, I was aware that getting published is not easy. It's actually really hard, and you read all the kind of stuff about how to get an agent, and I found a wonderful self-help book in America on how to write a proposal, because I did a Harkness Fellowship in America, and I found this marvelous book on how to write a non-fiction proposal, and it was like a recipe, and I can follow a recipe, so I put that together, and because it all seemed a mystery to me. You know, I come from a working class background, and this was all a very different world for me. So I like it when I love the way that in America you can find things that kind of make those things clear, sort of accessibility.
That's the selling point of America, isn't it?
It's one of them, yeah. There are others that.
Yeah, others.
Yeah.
Well, apart from that, again, apart from the obsessiveness, perfectionist, the other thing you mentioned was anxiety. It looked like your symptoms started more with anxiety than anything else.
Yes.
What was going on there?
I had tremendous examination anxiety, and I've had it all my life. I can't tell you how happy I was when I knew I'd never have to take another exam. But school exams, music exams, anything that required performance, and it was really bad when I was at school. And then that, of course, carried on to medical school, the worst possible torment being a spot exam in anatomy. Anything where you know that anything that you do in this second might change things. And that, you know, by the time I got to medical school, that was really quite bad. And then I think, I mean, it wasn't, no one said it was depression, but I had a period when I was really quite down and unable. I really wanted to avoid going in anywhere and leaving the house, and just stayed in and fairly obsessively wrote myself the most complicated revision timetable. You know, I had the minutes of my waking day charted out, and I've always been anxious about having OCD because my brother had OCD very severely. But I know that I do have obsessional thinking, and I can get obsessional about things. I have thoughts that I have difficulty getting rid of. And there is a big overlap between depression and OCD. I have problems with rumination and ruminative thoughts. So by the time I was a medical student, by the time I got to my finals, that was really quite severe. And but I got through them with the help of a psychiatrist.
Okay. So much already within the early minutes. But let's go to the vulnerability. You talked about doctors kind of being on the being vulnerable, but at
Yeah.
the beginning you talked about trying to explore, trying to make sense of why you got depressed. But you clearly said it was difficult. Did you have any biological triggers, or were they mainly environmental? And you talk about the family history. Do you think it's biology more than anything else in your case?
Well, I'm a biopsychosocial psychiatrist, and that's the way I was trained to think of all three. And I would say that I had biological predisposing factors as well as psychosocial ones. My mother had quite severe anxiety. She was on benzodiazepines for that. My brother obviously had OCD, and my father had periods when, certainly in his later life, when he would just retreat to bed for a few days and wouldn't get up. And I think he got depressed. He was also socially extremely anxious. It was extraordinary. I mean, at the time, I didn't realize how odd it was. But when I was a child, he wouldn't go into shops. He wouldn't go to the library and choose his own books. He had he had to give you a description of what he would like to read, and then you had to go and find it. He wouldn't go and try clothes on. My mother had to arrange to bring clothes home, and I think in retrospect this was social anxiety, and I've experienced some of that myself. But I think on both sides of my family there were undoubtedly some biological factors. But I think one of the biggest, I think my relationship with my mother was very difficult, and that was a big stress in my early life. And the impact of my brother's mental illness on the family, a major impact on my childhood. I mean, living in a household with someone who has severe OCD, which at the time wasn't recognized as OCD. They had decided that he probably had some learning problems. And it wasn't until I got to study psychiatry as a medical student that I started to think this might be OCD. And, you start to sort of read the textbooks and think about the way your brother is behaving. And he had some rituals, very obvious rituals. And so that was really stressful. Because it really was a daily issue, getting him out of bed, getting him dressed and going to school, getting him to get into bed, because his rituals were all around getting up and getting dressed. And he's had quite a lot of psychiatric treatment and remains very disabled even now. So you're looking at the severe end of OCD. So I'm fortunate that I don't have, those kind of problems. But I think, I think all of that kind of made me vulnerable to having mental health problems when under stress. And so I'm very aware of my, the kind of stresses in my life that tend to trigger off episodes of depression.
And deciding to go into medicine, was that an attempt to slay the beast? Let me put it that way. Is that you're kind of trying to overcome the anxiety and all that at the background? Because medicine is well known to be a
stressful
most stressful course ever.
I don't know. I mean, I wrote in the book a bit about it. I did very well at school, and I knew that the school had high expectations of me. I wasn't entirely sure my parents did. I know they, because no one had ever been to university, but the school did, and did very well in science. And where I went to school, people who went to university tended to come back as teachers. And I really didn't want to be a teacher. I thought I can do better than that. And there were one or two others that were going to do medicine. So I decided that's what I was going to do. I really had very little idea what it would involve when I decided to do that. I'd never spent time with a doctor. I'd never done anything of the way that students would now, going and shadowing and spending time. My knowledge was so limited, but I knew I wanted to get away from home, and I knew I wanted to do something that was academically quite challenging, and that's what I did. So,
and to the benefit of the whole world.
Yeah.
So you touched briefly on perhaps the early episode of depression you had. But that wasn't too bad. When did you really have an episode that was clearly this is depression? How did that manifest?
I was working as what would now be an SPR, a senior registrar, and I had been given that job without passing my part 2 of my membership, which today just wouldn't happen, but 40 years ago did. I had done well in the master's exam, our local exam, and I was struggling with a heavy clinical workload and trying to pass the exam. And my mental health just really started to deteriorate. I ended up, I also managed to get salmonella around the same period as well. Altogether, I wasn't in a good state, and I failed the exam. Okay. And then I ended up really, really down. It wasn't diagnosed as depression, but I did start to see a therapist at that time. A colleague said, "You don't look well." And it was arranged that I saw a therapist, and I started to have psychotherapy. And in retrospect, I think I was depressed. I mean, a colleague of mine who I saw not so long ago, who I worked with then, said, "You were depressed all the time then." Oh. But I didn't recognize it. I thought it was exam anxiety, but I was really down. And then I got through all of that. And then in I think my 3rd year as a consultant, in the early 90s, I had my most severe episode where I reached the point where I was just really struggling to get out of bed, lost quite a lot of weight, and really felt suicidal on that occasion. It was extraordinary. I mean, I just found it really hard to kind of re-engage with life after that, and it took quite a long time to get better. I had antidepressants, and then I also had lithium added in, and that combination actually helped me to recover. And then I went back to psychotherapy, but it wasn't an SSRI simply wasn't enough for me. And a combination, adding lithium in 50% of cases actually helps. And that really, really helped me. I really started to recover then, and then I had some more psychotherapy. But that was probably the most severe episode I've ever had. Because I really retreated from life and found it very hard to get through that.
You talked about, I think, battling the system. That was kind of big. Yeah. Was that a major trigger at the time then?
It was. I think I've always been one of those people. I'd been one of those people who naively believed that if you were telling the truth about something and you knew that something was right, then people would listen to you. And I hadn't yet learned that the NHS just doesn't work that way. And NHS management doesn't work that way. It was a fairly toxic environment. And I fell foul of a bullying manager, and as did a couple of my colleagues, but I think my mental health suffered probably more than them. And there was a period when it felt like, oh, this is the end of my career. That was why I think I got very, very down. You kind of realize that you're in the wrong place at the wrong time, and you're trying to do things that will improve patient care, and then you are looking back, I realized that all three of us who were having problems were women, and I'm sure that was something to do with if my male colleague, when he arrived to work with me, stood up to them, then he was being assertive, whereas I was being just difficult. And I did get distressed because my mental health was going down. And so then I was treated as someone that they'd actually probably prefer to be rid of. I was told that there'd been complaints about me, but I never found out what those complaints were. No one ever told me what those complaints were. And it was a very toxic environment. And in the end, the manager was actually, the person concerned actually departed due to financial irregularities, but was paid off.
Okay.
And I gave evidence to an inquiry, the results of which were never published. But the board was, the new Labour government came in 1997, the board resigned, and things started to change. And for a while, things improved. But it was a marvelous learning exercise in how some people can just be very charming to people in power and retain their positions, as I'm sure you know.
Yes.
And that person had friends in high places. So it was a very difficult time. And my husband supported me a lot through that. But in the end, I moved into doing some research in primary care. So I was only in the NHS half the week. And that for me was a tremendous boost, because I didn't have to be. I was slightly disengaged from it all. And they had less control over how I spent my time. And I do think for doctors' mental health, having some sense of control over your day is really important. And it certainly was for mine.
I think the system tries to take away that control.
It does.
Yeah. Yeah, and some people know how to play the system, obviously.
Yeah.
Okay, just going back to the treatment you had, you did say lithium helps in about 50%. I had this idea in my head that lithium is mainly for bipolar disorder, so that kind of...
It is, but it's also used in depression which isn't responding to antidepressants.
Okay.
And I used to use it myself clinically.
Okay.
And it's still used. It's still a sort of second line, third line treatment, adding in lithium. The problem is that there's no guidance really on how long to keep someone on lithium. And so at some point you have to come off it. And I was on and off it over a period of a few years, until I started to have some problems that were discovered with my cardiac rhythm.
Okay.
And it wasn't clear whether that was due to the venlafaxine I was on or the lithium. The cardiologist thought it might be the lithium, but I have been discovered to have prolonged QT syndrome. So that was probably made worse by the medication. And now I'm on a beta blocker for that.
Okay.
But it's, I think people often, I think we were only just then beginning to understand the added risk of that various psychotropic drugs have in terms of physical mental health. I think we're much more aware of that now.
And you've mentioned the SSRIs, SNRIs, and kind of gone through quite a lot of that.
Yes. I had various SSRIs. I've had duloxetine and venlafaxine, and I've stayed on duloxetine, and I'm still on that. At one point, I was also treated with bupropion as well, which isn't licensed in the UK for depression, but it's used a lot in North America. And the psychiatrist that I was seeing had me on a combination, which, because there was a period in my early 60s when late 50s, when I was really having problems again with mood that just wouldn't improve.
And just going slightly off course, how far are we with precision treatment in psychiatry? Is there a way to, are there any biomarkers to suggest which patient might benefit from which part, or is just kind of still?
I wish we did, but we don't.
Yeah.
Some people, we know that, the average is not that helpful, because some people do really well on antidepressants and some people feel worse. And we're not very good at predicting who's going to improve and who isn't. 30% of people will improve on placebo. 45% mean will improve on an antidepressant. But within that, there is vast variation. And there probably are biomarkers, but we haven't discovered them yet.
A lot of research to be done.
Yeah.
And then, of course, the therapy aspect of it, which you explored quite in detail. So you had a bit of earlier on, and then you talked extensively about E, capital letter E, who was your therapist for a long time.
Mm-hmm.
And you developed a relationship which seemed to help you. So I was going to ask, really, how much is therapy depending on the personality of the person providing the therapy? Because some of the memos I've read, once the therapist resigns or retires, it's kind of catastrophic for the person with depression. How much is that a part of it?
When you're working in psychodynamic therapy, which is where you are exploring the impact of earlier relationships in your life on your current ability to cope in the world, the relationship that you make with your therapist is actually part of the treatment. It's absolutely crucial. And you do reenact some of those difficulties that you had in earlier relationships within therapy. People do that. And that relationship, that therapist-patient fit is very important. And if you don't fit, then it doesn't work. Cognitive therapists will tell you that relationship doesn't matter. Some of them will. The more sensible ones will tell you that it's actually also really important, because you have got to be able to get on with your therapist, but you don't make the same kind of relationship with a cognitive therapist. You need to have trust. You need to be able to work collaboratively. You need to be able to respect each other. If you don't have those, then cognitive therapy won't work either, because the cognitive therapist has actually got to work quite hard at engaging you as well in doing therapy. But I was fortunate. I had a cognitive therapist who I think did engage me, and I was able to work with them. But psychodynamic therapy, where you really are looking at what happens in relationships, and you deal with your life difficulties through that relationship, and so it's absolutely central. And it was difficult. I think he helped me enormously in the earlier period I saw him, but he did he did take his own life, and that was really, really awful. And I did, discover afterwards that he had been sacked for behaving inappropriately with patients, and I guess I knew quite early on in the time I was seeing him that he had his own difficulties. It was easy, I was able to pick that up, but he still, I think he helped me he helped me to make some really big changes in my life, which, I wouldn't be here if I hadn't made those changes. So I, but I'm also aware, and you know, I've learned more about this in recent years, about the harms that can happen within therapy. Because when you have that kind of powerful relationship, it can also damage as much as it can help. And that's something that I'm afraid is all too common.
Are you still needing any form of kind of one-to-one therapy?
No, I did think about going back to it at one point, 3 or 4 years ago, but I haven't. I think that during the period sort of before my menopause and afterwards, my mood was affected. It did affect my mood, and made I think it added to my vulnerability. It made my mood problems more intransigent again for a while, and that was during a time when I was seeing a psychiatrist. And I did think about going back to therapy, but in the end, I didn't, and I've managed to get on with life. I had a relapse when I was put on an antihypertensive, which my psychiatrist at the time said was not uncommon. He had seen it, so physical health becomes part of your vulnerability.
You touched briefly earlier on about becoming suicidal with that worst episode of depression. How close did you get to, or how much did your thinking go in that regard?
I think there's been a couple of times in my life when I've been suicidal. I didn't act on it, but I think I came close to acting on it. And it was just tremendous feeling of hopelessness, just not being able to see any way out of how I was feeling. And on both occasions, I was able to talk about it, and I was open about what I'd been thinking and shared that, and that helped to move me forward. But it's certainly something that I have experienced as being there when I've been very depressed. That utter feeling that there is absolutely no way out for me out of how I feel. I think it's really important not to underestimate that when you see patients, and not to say, of course there is, you've got everything going for you, because that is just not how you feel. It felt like my life was, there wasn't a path forwards. I saw people who were able to just stay with me and acknowledge that was how I was feeling. And that was really, really important. And I haven't felt like that for quite some time. I felt like it a few years ago, but not recently.
And the other thing you talked about, which I know has been linked to the suicidal feeling, is the pain, trying to get rid of the pain of.
Yeah.
That what is that pain like? It's a physical, mental. I've seen that crop up so many places. It's not just a mood thing, is it?
It's not just a mood thing. It feels physical. It feels like your body is heavy, that you have a heavy, for me, it felt like I had a heavy weight pressing down on my chest. And some of it is probably related to tension because of agitation, but it feels physical. And I think for me, it's the kind of thing that there's just no separation between mind and body, that you do have this, it's, for me, it's always been a very physical feeling of feeling, well, as I said, in my chest, like a weight, and that you just can't shift, like you're wearing a straitjacket and you can't move. It's a it is a physical thing for many people, and it certainly is for me when I felt like that. And you feel bodily changed, and I've felt like that, and I guess that's one of the things, when I've got unwell again, I've recognized that feeling coming back. And you recognize this change in how you perceive your body. It's really quite shocking, really, how you sort of notice these changes.
Going off slightly, the issue of breakdown of important relationships and grieving as being triggers. How have your relationships helped, and how have they made things worse for you over time? You talked about your parents, obviously.
Yeah.
Um,
I am estranged from my family, although I do occasionally hear from one of my brothers. And that's difficult. I think people often don't understand family estrangement. They don't understand how common it is, actually. And you can reach a point where being in contact with your family actually just triggers off you feeling unwell. And I think I've had more support from friends than I ever had from family. Friends have been tremendously important, and my husband has been tremendously important. And that kind of support, I never had that kind of closeness with my family. And it's about people with whom you can share what's going on inside your head is really important. I had a teacher who was Canadian who used to say, "With whom do you share your distress? Find out from people, who do they share their distress with?" And for some people, the only person that they ever do that with is a doctor, or a priest or someone, but they have someone. And I do have friends and family, my husband, who I can do that with, which is part of how you stay sane, really, I think.
yes, I think relationships are a double-edged sword, then, clearly, from
Yeah,
what you
they
said.
are. Yeah, absolutely. Yeah. Yeah.
Um,
Families have all sorts of expectations of you,
hmm,
um, which can be difficult.
yeah. Can't do with them, can't do without them, in a way.
Yeah. Mhm. Yeah.
Um, the other thing you talked about was, you said you were beginning to learn the need to nourish your own soul in order to
Mm.
prevent relapses
Yes.
rather than simply mend. It's kind of a preventative approach. Apart from
Mhm.
medication, what do you do? What do you mean by nourishing your soul?
I mean by allowing pleasure into your life, really, and it not being solely about achievement. And I think that's something that's really important for doctors. I think we spend an awful lot of our lives just passing exams, doing stuff, working incredibly hard, find it really hard to spoil ourselves and to have time when we're not thinking about what we should be doing. And taken, it took quite a long time after I retired to really achieve that. I still find it very difficult, but I enjoy, trying to remind myself of the things that I enjoyed when I was young and rediscovering those, I think, is really important. Buying books that I want to read rather than things I ought to read. I love reading, and I spent a lot of my life, reading books that I had to read in order to learn. And, now I just love reading. I love non-fiction, but I love reading about things that are marvelously obscure. And I love traveling. And I used to do quite a bit of that with work. So I went to some fantastic places. But now I just love being able to go and spend some time somewhere and enjoy that time. And, not feeling I have to do things. And I think we just don't, as doctors, we're extremely bad. The kind of people who do medicine are achievers, and we end up really making life very hard for ourselves. And the NHS takes advantage of us because that's what we do. I never finished work at 5 o'clock ever. So it's it's about taking care of ourselves, but also it's more than that. It's actually thinking about all the things that you're interested in that you'd rather do than medicine. And I've got interests and things that I love reading about that sometimes are a bit obscure. My husband wonders why I buy books. I've just been reading a marvelous book about the ethics in medical experimentation. And okay, it's to do with medicine, but it's nothing to do with what I had to study. But it's still fascinating, and I enjoy reading it. So just indulging myself.
Avoiding, that seems to be the recipe to avoid burnout, I presume.
Yeah, I think it is. And I think we're not very good at doing that. There were times I would burn out and then get depressed. I know that's what happened. And then usually there'd be some problem with the system that would just tip me over the edge. I was working at a time when it was slightly better to work in universities than it is now. I think it's getting extremely tough to work in universities. For me, the university was an escape from the NHS, but I think they have become more difficult. But I did find the combination of academia and medicine. I found being a medical academic a very satisfying life because I had time to research, and then I had time to try and put some of the things I researched, I could actually try and put them into practice in my everyday clinical work. And that was wonderful.
Almost every doctor I've interviewed on the podcast has highlighted the importance of being both a clinician and an academic, as a researcher, kind of melding the two. And there's a kind of a regret that is becoming vanishingly rare. We've known about this issue for a long time.
I know. I think it would help enormously. The young doctors I know, and I'm not supposed to call them junior doctors anymore, but the younger doctors I know who get time to do research into something they're really interested in. And I used to supervise master's research projects, and I could see how much they actually enjoyed doing it. They hated the writing up, but they really enjoyed going and interviewing people and going and doing that kind of work, because it was investigating, trying to disprove or prove a hypothesis, and they really found that fascinating. And it's fine as long as, part of the problem is universities have become so concerned about you bringing money in, and no longer, I think, as much places of learning as places of earning. And I did work with professors who, when I was in training, who never had to think about those things. They were just concerned with knowledge, and You know, they encouraged me to read obscure books about psychopathology, which was absolutely fascinating, but not the sort of thing that would ever get you a research grant. So I do think there's a problem with universities, but I do think being a medical academic was a very satisfying life, and it's a great pity that that it's not seen as something that could help doctors to lead a more balanced life, because it helped me to lead a more balanced life.
The other thing you talked about was the things you learned from your patients. You said in the last 30 years, listened to many stories of depression and despair. What did they teach you? What did your patients teach you regarding depression?
Well, they taught me that it's not just a list of symptoms. And, you know, it's too many times when I was teaching, I would get asked I'd ask what depression is, and people would just reel off low mood and loss of interest or pleasure and 4 out of the next, and you sort of say, what's it like? What does it feel like? Don't give me, life is not a DSM explanation. Tell me about what people have told you it's like when they're depressed. And it's different from person to person, but there are some things that are common. And yes, they are symptoms, there's no doubt about that, but it's about trying to get inside someone's head and really empathize and really kind of put yourself in those shoes and try and understand what it's like to be them inside, living their life. And you don't have to like a person to do that. You may dislike them, they may annoy you, but you've still got to try and empathize with them. And that really was what my patients taught me, was the need to try and really see life from their point of view. And that was what, the doctors who helped me, the people who helped me did that. I felt they were able to listen and understand where I was at. So it is about engaging. It's about more than just asking people questions. And so I learned about how history taking is actually just not a one-way process. It's about engaging that person in a conversation. And that's what I learned. I learned a lot about I learned a lot about the importance of people's stories, that from their perspective, they have a story to tell you about what's been happening to them. And you need to listen to that story, because otherwise they won't feel listened to. If you just ask them a list of symptoms, they will not feel that you have listened to them. And you will not know anything much about them. You'll not know who they are, where they come from, how it's affecting their life. So for me, medicine has been a lifetime of collecting those stories. And that I just found that fascinating. And I think psychiatrists, we have the time to be able to do that. I never had time to do that in anything else that I did.
I think the rest of medicine needs to learn from that.
Yeah.
There's a move towards pre-consultation questionnaires and all sorts of things to try and reduce the consultation time.
Yeah.
But okay. And you also said your illness, having depression, has also helped you to be a better doctor. Would you say generally that physicians who have been wounded themselves make better doctors, or is that too much of a general?
Not necessarily. I would say not necessarily. I think it's not about you.
Okay.
It always has to be about the patient. And too often, I do meet people who have been wounded and who have experienced their own problems with their mood, but sometimes they are making assumptions about the patient based on their own experience. And it's really important not to do that. And it's also really important not to use medicine as a way of helping you to feel better about yourself, which is, I think, one of the crucial mistakes that many of us make. We get our self-esteem from being good doctors. And so I think you have to be very cautious. I know that it has helped me in that I think it helps me to listen and to be able to understand. But when it comes to the meeting with the patients, that meeting is about them.
Okay.
It's about their experiences. And it taught me to listen and to be with people.
Okay. Okay. That's insightful. That's good.
Yeah.
I was getting this idea that you're a better doctor if you've had an illness like that, but clearly not.
No,
Okay.
not necessarily.
No, not yeah.
No.
It could
Yeah.
even
You still need the skills. And I have this discussion with people with lived experience. Having lived experience doesn't make you better. You still need the skills and to be able to interact with people. You just might use them differently if you've been there.
And another thing you mentioned was even though doctors are more vulnerable, it looks like psychiatrists particularly more vulnerable to depression and oh,
Yeah, they are. The psychiatrists are more vulnerable. And I mean, amongst the medical profession, we know that if you look at the suicide rates in the medical profession, we know anaesthetists are at risk. We know psychiatrists are one of the risky groups. And yeah, anaesthetists, because of the availability of and ease of access to ways of taking their life. And I know that amongst anaesthetists, there is a great deal of awareness of that. But psychiatrists are also among the riskier groups as well. And it's, I think the women doctors, I think, are also at higher risk compared to women in the general population. And I do think the issue of stigma is still a major problem in terms of people actually going and getting help. And of course, in medicine, we've also got an issue with alcohol use as well, which we've always had. And I don't know if that's any better than it was when I was in training, but I went to a Scottish medical school, and there's certainly evidence that people drink more by the time they've left medical school than when they entered. Certainly there was old research that showed that. Yeah, so we are a risky group.
I asked because I have a personal interest in this. My wife is a perinatal psychiatrist. Um, and she talks about this peer group support meeting that they have to have regularly just to prevent kind of burnout.
It's a very good idea. I think having peer group support. I had a colleague who I would talk to, and we would talk to each other, and we did provide each other with support. And for me, that was important during the time when I was going through particular problems in the trust I was working in. But I think local peer group support, as long as you have a peer group that works well together. If you have a dysfunctional peer group, then that will not be helpful.
Interesting. And she would definitely ask me if I didn't explore this. So I'm going to ask you this, your latest book, Out of Our Mind, because again, that's kind of a perinatal issue.
Yeah.
Do you want to give me an insight, a peek into what that is about?
Yes, it's it's a book about women's mental health broadly.
Okay.
I really wanted to. A few years ago, I was asked to speak at a debate in Manchester for Women's Week, and the proposition was this house believes that men are the losers now. And I was asked to speak against that. And I could have spoken for it. I could have made an argument, but I was kind of glad that that wasn't the case, because I'd been working in Salford at the time, and, you know, women are not winning in Salford. I'd been working with largely white working class women who were struggling. And it's I've also spent a lot of time working with women from ethnic minorities, and I was really aware that women's mental health is something that we weren't talking much about generally. I mean, we have specific areas like perinatal psychiatry and people who work in domestic violence and so on, but we weren't really looking at the whole picture. We were focusing on men because of the higher suicide rate in men. And so I wanted to write a book that kind of brought the whole picture together through the life cycle. So I start off with young women, and I work right through to older women through depression, women's work, fertility, domestic violence, gender issues, and right through to old age. And I interviewed a lot of specialists and experts, but I also recruited a lot of women to talk to me about their stories and experiences. So everyone got a chance to read what I'd included and to correct it if they wanted to. So I had people who wrote me letters saying you've got it all wrong, and rewrote what I'd written. I had a whole chapter on the whole issue of borderline personality disorder. And so it's really about trying to even up the balance, really, and saying, actually, you know, women are still having a hard time. We may not take our lives as often as men, but we harm ourselves more. We experience more post-traumatic stress disorder, more abuse in childhood, and we even have twice as much Alzheimer's disease as men. So right through to the, you know, all of these things, and there are all the women's mental health issues, all the issues like eating disorders, which are commoner in women, which don't get the investment. I was amazed to find out that, you know, 60% of eating disorders beds are now in the private sector. So it was 5 years work, and Cambridge have published it, and so it's for a general readership, but I think I'm hoping it will get our profession thinking a bit more about, you know, thinking about women, about thinking about policy more generally towards women, that a lot of what we do is gender neutral, which means that women don't really get much of a look in. And and I spent a lot of my life treating women with depression, and at the moment, you know, the entire focus for treating women with people with common mental health problems is about work, not about recovery. So, you know, it's about just taking that more seriously. So if I've gone on a bit, that's what it's about.
Important.
Yeah.
And clearly you
something I felt very passionate about, because those are the women I've worked with throughout my career. You know, 2/3 of my patients have always been women, because I had an interest in depression, anxiety, eating disorders, grief, and so that's been what those have been the people that I've met.
Well, I wish the policymakers are also listening and perhaps reading the book. I will try and get it and have a look. I've had a look at a few books on gender medicine, and clearly show disadvantage women have, even with
Yeah,
things like heart attack and
absolutely. Yes.
yeah.
Quite shocking, really. Stuff that I didn't know about how women women in have been ignored in research.
Yeah.
Yeah, yeah,
Let's hope it makes a change. Um,
yeah.
and then I also wanted to ask you about this Storm, the suicide prevention
Yes.
organization. How long has it been, and what successes have you had?
Well, I'm not involved anymore.
Oh,
I have stepped down, but that began as a small research project in the 1990s with some Department of Health funding, and then we got some MRC funding, and Lewis Appleby was involved, and then people kept coming and asking me if they could have training. And so we set up a social enterprise eventually. The university, we set up training through the university, and employed one of the trainers from the research. And then we spun off as a social enterprise. And it's an ongoing concern. It's still going strong. So it's been going now, I think, for about 15 years now. So the university submitted it as one of their impact things, but it started off as a relatively small project, tiny in fact, when I was in Preston, and then became a bigger project, and then has gone on to employ people. So it employs a small number of people, a handful, but they train people who deliver the training. So, and a lot of it is done online now.
excellent.
That happened during COVID. They used to travel everywhere, but now it's done online.
Yeah. COVID has shown that that is possible for many things.
Exactly, exactly. Yes.
So I suppose it highlighted an unmet need, isn't it? Suicide is kind of in the shadows of stigma and all sorts of things.
Yes. I mean, I think that training alone isn't enough. You have to combine that with all sorts of other things in the community to prevent suicide. But your professionals need to be trained in how to talk to people. And we know that questionnaires are unreliable. You actually need to be able to sit down and have a conversation with someone. And that's the work that we're doing, and used video in order to train people in those skills. And that's work that I started doing in the early 1980s when I worked with Sir David Goldberg, and that was the work that he was involved with. And I got involved in teaching GPs using video, and that was work that then went on, and I travelled around and did that in different places, even in Russia.
Oh, okay.
Yeah, in Siberia, I've been to Siberia 3 times.
That conjures up a picture in my mind.
Oh,
Well, worthy work. I think it's a big
mhm.
unmet need.
Yeah.
I was going to ask you about what the future holds for depression, kind of more in the scientific area. And one of the things you mentioned in your book was the structural changes seen on the brain in people with depression. Is there a lot that can come out of these kind of research into structural changes in depression that can be helpful?
Well, I think things have moved on a bit since I wrote the book. I mean, the big area now is inflammation,
Okay.
and people looking at the association between inflammation and mental illness, and inflammation in depression. I've been waiting for the big biological breakthrough in depression for the last 40 years. I was told it was just around the corner when I started psychiatry, and it's still just around the corner. I think we know that biology plays a big part, but we know it's incredibly complex and we've still got a phenomenal amount to do. And I don't need to tell you that as a neurologist. You know that it's phenomenally complicated, and we have to keep a biopsychosocial perspective. But I think, it's interesting and there are people working on it. And maybe it helps us to understand some of the interactions between physical and mental illness. And but inflammation is currently the big buzzword in depression.
Okay.
Yeah.
I need to update my knowledge on that then. And what's the major question you think that we need to answer more on a practical basis regarding depression? What are the major questions or uncertainties?
I think we need better antidepressants. I think we still need, they've largely stopped investing, and the money went out of psychotropic research, but what we have are not good enough and have lots of problems, and we've still got a lot of progress that needs to be made there. And we have got to be better at treating people who have what would be called treatment-resistant depression. We're still not good enough, I think, at helping people. And it's not so much about research, it's about implementation in the NHS. I've always seen far too many people who don't get really adequate treatment and then remain chronically depressed for a long time, and then eventually get told they've got a personality disorder, and I think that's a real issue. And that's always been a bugbear of mine, but I think remains a problem. When I was in the US 20 years ago, they demonstrated that if you get psychiatrists and GPs and to work together, you can improve outcomes for depression, and you can improve outcomes for physical illness in people who are depressed as well. We're just not very good at doing that kind of stuff here. It's amazing that it can happen in a US healthcare system.
The NHS.
But the NHS has largely been dominated by psychological therapies alone, rather than thinking about combination and collaborative care. And collaborative care, I think, it's been rolled out across the world, but the NHS has missed out on that. And we did some of the trials I did before I retired, were into collaborative care models that I learned about when I spent a year in the US. And so I'm disappointed that we've not managed to. We really need to be much more systematic at how we treat people with depression.
And are these psychedelics holding up any hope for the future?
They seem to for some people, but I think you've got to be very cautious about safety issues. And in some areas, it seems like a bit of a Wild West. And you have really, but I think, anyone who can demonstrate improved outcomes with treatment-resistant depression is definitely onto something. But I'm not. I'm more convinced it's the combination of the psychedelic and the psychotherapy. It's the combination of the two, I think, that's key. Too much emphasis on the psychedelics. But some people seem to do better with them. But again, for me, it's always about caution and about doing things safely. There's a real opportunity for people to get in there and do the wrong thing.
And then 10 years later, look back and say, we wish we hadn't done this or that.
Yes, exactly. Yeah.
Okay. I'll probably come to my last question. I was going to ask you about lessons, but I think we've kind of covered all the lessons you wanted to project in the book. Are there any you want to highlight at all? Kind of what readers should take away from the book?
I think the importance of relationships relationships are one of the things that affect us more than anything else in our lives, and relationships are key. Your early relationships affect your later relationships, and that's why I think therapy is so important. It's not just about taking tablets to recover from depression. It is about what happens in relationships, and not to give up.
Okay.
You reach those points where you feel like giving up, but talk about it with people who you trust. And I've always felt that, throughout my life, there were times when I had to carry hope for my patients. I was the person who thought that things could improve, kept that sense going for them, and other people have done that for me. So seek out people who you feel that you can trust, share how you feel, and don't give up.
Powerful message there, obviously.
Yeah.
Okay. Do you have any books you would like to recommend at all for readers, apart from depression?
Really, really simple things. If you want to read something really heavy,
Yes.
which some people do, I was looking at my bookshelf and I was thinking, well, I've got William Styron's Darkness Visible, which really does describe what it's like to be depressed. There's no doubt about that. I mean, that's why I say it's not just about symptoms. He really gets into the experience. But if you want something really light and you want something that you can pick up and read a chapter at a time, James Withy, who's a therapist, I'm not sure, I think James is a qualified therapist, but he works down in Brighton and he's written a whole series of really quite funny books about, how to tell depression to piss off. And I really like that. At one point he says, if all else fails, get a cat, and I know what he means. But he's just very funny. And his book about depression and his book about grief, they are both very good. And they're not hard work. And when you're depressed, you really don't want something that you're going to that's going to make you feel worse. You want something that's going to make you think, one mouthful at a time, and think about things you could be doing differently. And his books just made me laugh. He asked me to review them, and I wrote, I'm on the cover, I think. But I really enjoyed reading them because they made me smile, but they also made me think. He also wrote another book called The Recovery Letters, where he collected a whole load of letters from people, which they would write to somebody in order to help them recovering from mental illness. And so it's a whole book full of letters. And again, it's another fascinating book. It's just different. So you can read something that's really heavy, which might make you feel worse, but nevertheless, read it when you're well. Or you can read something that's, I think when you're depressed, you just want something that you can read a couple of pages at a time. And I found his book on grief really, really good because he understands it.
Okay.
Yeah.
That's a new one for me.
Yeah. They're just popular books, but they're great because they're, and when doctors are depressed, you can't read. So you need to read something.
And you can never go wrong with cats, I guess.
No, well, he was just funny the way he just said it. He said, if everything else in this book has failed, we'll just get a cat, and I know what he means because they've saved my life. Animals, we completely underestimate the importance of companion animals in people with mental health problems. They're tremendously important. And there's research to prove that. So,
Well, that's a good place to end on a high.
absolutely, yeah.
Linda Gask, thank you very much for participating in this episode of the Neurology Lounge podcast. I've enjoyed it and I'm very grateful indeed. To my audience, thank you for watching or listening to the podcast. To make sure you don't miss the next episode, why not subscribe to the iTunes, the YouTube, or the Spotify channels? And whilst waiting for the next episode of the podcast, you might want to check out my book called Surfing the Brain. Or for the more academic aspect of neurology, I have a website called Neuro Checklist. But until then, thank you very much for your time. And Linda Gask, thank you very much. I'm very grateful.
Thank you. Thank you for asking me. Thank you.